Bismillahirrahmanirrahim. Thank you very much, Mr. Chairman, for the kind introduction, and big thank you to Hisham Gaber for this fantastic meeting. Very impressive. I'm going to talk to you about laparoscopic surgery in severe endometriosis, a fertility perspective. We're going to touch on the background, extensive pelvic endometriosis and surgical objectives while laparoscopy, and minimal access surgical approaches and the evidence so far. Before we do the summary, I have no undisclosed interests. Rokitansky, we've heard his name earlier in the morning from Professor Arif Darwish in the Mullerian Agenesis. And he's the one actually who first described endometriosis in 1860. And endometriosis is a disease that affects 6 to 10% of females, and in fact very famous females, not only this is Emma Spice from the Spice Girls, and also Marilyn Monroe. And it can occur in different parts of the pelvis, but also it can affect the upper abdomen, the thorax, head and neck, and other parts due to several theories. And the pelvic common sites are listed as you can see them here. The most common one is the pelvic peritoneum and pouch of Douglas and ovarian fossa as well. And there are some theories, genetic predisposition, pollution, or autoimmune, and that's not the subject of our talk today. The morbidity are actually multiple and also multiplied by other factors that can coexist with it, and the consequences on the quality of life and psychosexual well-being are massive. Scarring of the pelvis for complex ovarian cysts, bowel ureteric obstruction, hydronephrosis. We've seen patients actually with almost renal failure, very thin cortex that has developed over the years due to ureteric strictures. Subfertility, and as I mentioned, the psychosexual morbidity. The morbidity also leads to subfertility, and this is what we're going to touch on today as well, amongst other things. The extensive pelvic endometriosis is a category of disease or diseases that means there are significant abnormalities in the anatomical structures and arrangements and function of the pelvic organs. The problem has arisen from the gynecological organs, but also affects the bladder, the bowel. And as you can see here, you can have a multitude of pictures like ovarian cysts and adhesions, obliterated bowel Douglas, bowel involvement, either on the surface of the bowel or in the rectovaginal septum, bladder involvement, ureteric involvement, all distorted anatomical relations. As you can see here, there is an obliterated pouch of Douglas in here. When we do surgery for endometriosis, you have the options of either open or laparoscopic surgery. In fact, people who adopt the open surgery, they probably there are no facilities for laparoscopic surgery in their institutions, but previously it was claimed that laparoscopic surgery carries more risks to the patient, which is not the case and has been refuted by several randomized trials. The surgical approach to endometriosis has to adopt certain objectives: reducing pain, preserving fertility, restoring functions, or radical excision of the endometriotic nodules to treat the symptoms and improve quality of life. You need to have a balance between radical excision and restoration of normal anatomy, and also restoration of fertility or function. We use the laparoscopy for better visualization, fewer complications, less post-operative pain, and quicker recovery. And the minimal access surgical approach has to adopt certain guidelines, which is strict preoperative preparation, appropriate counseling, obviously. Laparoscopy surgery team is not, that does not depend on individual. A team has to be trained for this, and expose the structures that you would not like to remove first, or at least before you start excising other structures, circumstances. Thank you very much.
Thank you very much, Dr. Sekotory.